Hello, everyone, and welcome. My name is Erin. I'm from the development team here at Amref USA. It's really wonderful that you've all joined us today to discuss the future of healthcare in Africa and the impact of the USAID cut. Items are posted at the very top of the chat for anyone who may have missed them. And now I'm honored to introduce our featured speaker, Dr. Mercy Mwangangi, AMREF's Director of Health System Strengthening. A former clinician turned health economist, Dr. Mercy was a key architect of Kenya's universal health coverage pilot and has helped shape national policies like the primary healthcare strategy. She also led Kenya's COVID-19 risk communication efforts, emphasizing youth engagement. Today, she continues to drive transformational work across African health systems here at Amref. Joining her is Bob Kelty, CEO of Amref USA. Together, they'll dive deeper into the impact of the USAID cuts and what it means for healthcare programs across the continent. Bob, over to you.
Thank you, Erin, and good morning, everyone, and thank you. Really appreciate everyone joining, and I'm seeing a lot of new names, so I think I might just start with a little bit of context of who Amref is and kind of why we think we can do this call and why we're, I think, uniquely positioned to do it. So I'm the CEO of Amref USA. We are a satellite office of Amref Kenya, where we're based. There's 8 other offices like the US office. Our job is to raise funds, work on communication, advocacy, and kind of facilitate thought leadership. The US office is fairly small. We have 10 people, but very mighty. And so Amref was founded 70 years ago in Kenya. We're headquartered in Nairobi, and we work in 35 countries. A lot of those countries were actually implementing program, but a lot of it was we work strategically with governments, and we saw that a lot in our partnership with Africa CDC during the COVID outbreak and really doing strategic work. And I think that's one of the reasons we feel like we're well positioned to have this conversation. 90% of our staff is based in the communities that they live. We have about a staff of over 2,000 people across the continent. And so that's kind of who we are really briefly. We work on HIV/AIDS program, global. We're a partner of the Global Fund. I see MasterCard here, another one of our partners here. Comic relief. We do a lot of across the board, infectious disease, health security. We also have a university that we are launching a new campus in next month or two. And so I also see quite a few NGOs here, and I don't want to dwell too much on what's happened with USAID cuts because I think we've heard a lot about it, and obviously devastating from just a community aspect and from a person, from a lot of people being affected by it. But one of the things is that one of the other challenges is 1 minute a program's paused, the next minute it's canceled, then it's starting up again. And I think this is one of the biggest challenges. We go, what are our programs? And what do we tell our communities we're working with? And that's one of our the challenge that all these NGOs are facing. And I look at a lot of people ask us, how's Amref doing? Are we going to survive this? And it's like, so we've lost 20 USAID programs, about $22 million of funding this year. But the focus of the programs that have been closed have really been around maternal and child health, family planning, youth empowerment, and which is there's not a lot of funding on the scale that U.S. government does. I mean, one of the things that's really important for the U.S. government, or why U.S. government's such an important donor, not just because of the size, but the length of the grants they give. A lot of times they're 5 years. The way they fund, so it's really a strong partner, and it's been a strong partner for Africa, since the early 60s. We have two things on our slide, some data on the slide. And the New York Times did a really good piece kind of breaking down, what the human cost is going to be for these cuts by there. And I picked two that kind of really resonated with me. One is, the effect of polio. Amref has a polio project in Ethiopia. It was one of the first proposals I ever worked on, and 10 years ago. And Ethiopia in 2017 reached certified, polio free. And, now with the war and, the Civil War, it's really at risk again. And the project is a big consortium of organizations and donors. And so a lot of times we think it's just US government directly funding this. There were a lot of private organizations in this consortium. Once USAID pulled out, the whole consortium closed. And, there and then, everyone knows right now what's going on in Sudan and South Sudan and, the amount of food support. And one of the things we hear is, oh, we're not going to cut, nutrition and programs are there. Our Amref's US or our nutrition programs in South Sudan that were funded by UNICEF or US government through UNICEF have closed down in these kind of crises. So there's so many layers to this and of what's going on and and so it's just not straightforward. What becomes USAID? How does it become a funder? And, again, is a trusted partner? Um, we don't know. And, one of the things that was, we, Amref held our biannual conference, March 5th to the 10th, and it was in Rwanda. And, so I think, and it was, really, when I went over, I'm like, are people going to show up? What's it going to be like? This is, I think, our sixth conference we've done. And, almost 1,800 people showed up. I was one of the few Americans there. And so it was a really different dynamic. And right from the start of the conference in the opening plenary session, Dr. Katahi, who was our global CEO, spoke kind of really directed, not just the US government cuts, but the cuts overall. And, just said, we knew this was going to happen. We didn't know it was going to happen this way. Let's move on and focus on what we can do about it. And I think that really set the tone for the whole conference for me. It was a really inspiring, came back from the United States really motivated. And Dr. Mercy was at the conference. She hosted one of the plenary sessions. And she's the only plenary moderator who actually had walk-up music for when she started her session. So Dr. Mercy, I would love to hear your kind of thoughts on the conference and kind of your takeaways and what you felt.
Thank you. Thank you, Bob. I wish I had music here today, but hey, we're all seated in our homes, offices, in front of our laptops. But I'll just get straight into the conference. So the Africa Health Agenda International Conference is a convening that takes place every 2 years. And 2 weeks right before this convening, as you may all imagine, we were a bit fearful, wondering how we'd ensure that everyone comes in, considering that many of those participants are funded from overhead costs. But then we had a very successful conference. We had about 1,900 people in the room, and about 300 people joined us online, and participation from, I think, close to 34 countries, African countries, Southeast Asia, the US, Latin America. So very good representation. And Bob, I have to tell you that, the mood was upbeat. There was a lot of enthusiasm, which one may wonder, considering the circumstances that we're all in right now, particularly in sub-Saharan Africa. And really, the pulse in the room was very optimistic. There were a lot of conversations on, one, we knew this was coming. We've long had conversations on the need to really focus on domestic resource mobilization. And so a lot of, silver lining moments on, okay, great. So this has happened. How do we move forward? What are the things that we need to focus on? And many themes were emerging, but I would say for me and from observation, the top four were: one, a conversation needs to be held on domestic resources. A conversation needs to be held on the health financing architecture. And one of the plenary sessions that Bob was referring to, where I was moderator, the conversation centered on, okay, great. So what does the external financing bucket look like? And how do we ensure that it is now much better aligned to country needs? I know this is a conversation we've had from years back, all the way to the Paris Agreement on aid years ago. But this time around in the room, it was very electric and a lot of, okay, great, we all know this, so what needs to be done? A lot of conversations on PHC, very many sessions, both formal sessions within the conference, as well as huddling together around corridors on, great, what do we need to do to strengthen primary healthcare systems? Are they well designed? And I think for me, the most overarching principle was a call to action on system redesign. And so, this is what Amref then picked out and what we'll be working on, particularly because we're very closely centered with governments. We work with them shoulder to shoulder. And this call to action on, hey, let's have a really deep thinking around system redesign was also championed by different high-level delegation members who were there, including ministers of health.
Yeah, I mean, I think it's a really great point. You know, the way the architecture of the health system divide was so driven by donors. And we're all in these silos that we see, you know, these really limited. And I think that's something you'll talk about now. And the dinner
Yeah.
is like, this system wasn't set up to maximize efficiencies. And
Yeah.
love to hear you talk about the dinner you had with the ministers of health and their kind of feedback and what needs to happen.
Definitely. And as I jump into the dinner conversation, it's important for members to know. So we got into this hike, 2025, thinking about social determinants of health. So thinking about those non-health determinants that drive health outcomes. So again, very pertinent conversations. When we discussed health financing, it wasn't just about, hey, can countries move towards their Abuja declaration? The conversation started from, okay, are governments ready for this? What is going on in the economics ecosystem of governments? What is the debt situation? Is this the time to actually have these conversations and use this policy opportunity window that we have to really move the needle on this? And so then on the second day of the conference, we hosted a roundtable closed ministerial dinner. And this is our 7th dinner. Amref does host these dinners on the sidelines of a hike, as well as the World Health Assembly and UNGA. And so this was our 7th dinner, and it's a highly informal dinner. No program, no presentations, closed doors, Chatham House rules. And in this dinner, we had participation of the Minister of Health, Rwanda. He was co-chair, together with participation from Ivory Coast, Kenya, Tanzania, Malawi, Zambia, Sierra Leone, Africa CDC, and WHO were also present. And the conversation really was an echo chamber of what happened in the bigger plenary sessions. And we were able to have really, really fruitful insights emerge from that. For example, when it comes to the health workforce, 2 countries shared with us that they actually are highly reliant on external funding when it comes to ensuring that they have health workers, particularly for strategic programs such as HIV, TB, and malaria. Now, what was jarring was to hear from the ministers of health that in some countries, by simply having the withdrawal of this funding and recognizing, of course, the deleterious effect of this withdrawal, that they were able to have cost savings in their wages of up to $40 million. So simply having this move out and therefore then needing to integrate the staff into the normal government HR mechanisms, they were able to save $40 million. There were a lot of conversations, and it was interesting to see that juxtaposition. So some countries have already gone ahead, and Rwanda, for example, is miles ahead when it comes to HIV, TB transition planning. And this is again because of withdrawals that took place years earlier. And it was interesting to hear them share their examples and insights into how countries can navigate this. We had conversations about health security, and particularly noting that this may be an area where we may have continued funding. How do we then ensure that this funding is now better programmed to ensure sustainability? There were conversations on supply chain. And I do remember 2 ministers sharing that they currently have a red light sort of system in terms of how they're viewing the cuts. And the system is simply red, amber, and green. And for them, what they feel is highly strategic and that they can't drop off and almost may actually pursue a substitutive effect is when it comes to medicines and commodities. So the idea was, for example, for Kenya, about $300 million goes to HIV and TB and malaria programs. And so the conversations were we must maintain these budgets and therefore we must look internally to raise these resources to ensure that we have these commodities. And what I found insightful, it wasn't simply a mere suggestion of let us substitute 300 million for what we have. But further to that was how do we ensure we preserve some of the global supply chains that have existed, supported by USG funding? How do we pivot to other aggregation mechanisms that exist? Because we must leverage on the economies of scale. Then there were conversations on things that are an outright red, right? So a lot of the ministers shared with us that for them, without a doubt, they do not have resources to focus on elements of demand generation. They do not have resources to focus on programs that may be deemed to be, more, unfortunately, community promotion type of programs that involve a lot of heavy OPEX costs on capacity building. I do remember one minister saying he has asked for a brief on how he can reprogram all trainings into some form of virtual platform. There was also a concern on data, Bob. A lot of conversations and realizations that countries have actually had a lot of their TB, HIV, malaria, and surveillance systems supported through USG funding. And some interesting conversations even centered around ownership of that data. I'm sure you may be aware some of the projects that we even supported as Amref, where we were supporting data systems in Sierra Leone. Those were stopped, some momentarily, some were restarted. And there was a big conversation from the ministers who owns this data. Could we have negotiated this better? Is it time to actually have inbuilt home systems that are able to give us health information and intelligence, business intelligence? And so really a lot of, I'd say again, optimism, but a sort of palpable drive to, okay, great, what do we do? How do we move forward? What should we focus on? What do we let go of?
Thanks, Mercy. A lot there. One of the things I noticed is how fast people are moving. So the conference ended, what, 2 weeks ago, and all this stuff is going around. Kenya just released their report, very strategic on what goes there. Love to have you talk about what Amref is going to do in like 2 weeks. You've got you working with Chai, who we're going to partner with on this. Would love to hear kind of our strategic planning and how we're planning or how we're going to implement it. I think there's a
Yeah.
slide.
Thanks, Bob. And the pressure is on for us as Amref because we actually have an accountability structure that we walked into thinking that it's just an informal dinner. But the ministers are now waiting for feedback on how do we work towards transition planning. And so working with Chai, we've defined a frame of what we need to look at. Ideally, we would be looking at a gap analysis, but not in the generic gap analysis mechanism because there have been so many gap analyses done in the past. But this time around asking us, okay, great. So here's the gap and then the so what? So what's the pivot here? And then extending this further into, okay, great. And then if you pivot this way, from getting guidance from the ministers who were clear to tell us, these are the reds, forget about those. We're not keen on those right now, but at least for these two set of interventions, we need to know what we can do. Then there's a question on, will the pivots really lead to better health outcomes or will there be opportunity costs? And so part of this then involves not the normative gap analysis, but a gap and then the so what. And then this then would lead to development of transition plans. We are working to ensure that these transition plans are actually generated by the ministries of health themselves and that we come there merely as facilitators. And it would be interesting, to share with all of you. There are countries who've already started this process. Round the table, Zambia told us of how they set up some form of systematic process to come back to, hey, this is what we need in the short term. And what we'll be doing as Amref is curating this, doing a lot of process documentation, sitting there around the table, and a lot of iterative thinking as to what transition planning would look like. Now, different countries are in different spaces. Kenya, for example, is about to get into its new financial year. So there are a lot of conversations on how do we ensure that this transition plan makes a proper segue into the budget planning cycles. And that's the approach that we'll be using in different countries. And so, again, many of us have heard of transition planning in the past. We've all worked on different transition plans. The ministers pushed hard and said, let these be realistic, right? And this is sort of, one of the things that I'm really excited to see what happens 12 months from now. How will this transition plan not just be aspirational, but more realistic in the short term? And then probably have very interesting, innovative, so what's in terms of system redesign. There's an interesting element of all this. And, during the dinner, a lot of the ministers were saying, you know what, when all this is said and done, how do we ensure we keep checking on each other? How do we ensure that we keep translating these learnings? How do we set up a technical forum that would ensure the translation of these learnings? How do we elevate these learnings into our regional blocks? Does this mean that perhaps it may require some strategic review in all the different UHC plans that exist regionally in the different country blocks? And
Mercy,
so we see this as
I hate to
a
interrupt, but like
starting point.
we're like, this may have been too brief, but I would love you to get through the, oh, you've got an objective too. If we could go there really.
Fantastic.
We may have to go
Yeah.
over if people can stay.
Yeah, of course, of course. So yeah, so literally this is what we'll be doing. What will we be working on? Human resources for health, strategic commodities, lab diagnostics are key. People are asking us, how do we ensure USG investments are integrated in the lab diagnostics arena into early warning systems? So we'll be looking at that. And then, of course, adaptive leadership. A lot of questions on how shall we build capacities going forward? Should we bring back the good old on-job training mechanisms? Do we leverage on e-learning? And how do we ensure that, countries are actually able to move this forward? Part of our analysis, Bob, as I come to end, will also include a lot of country capacity assessments and a look at the unintended consequences of these withdrawals and then, of course, the system redesign.
Would love to hear just one more minute, because then I'd love to have a few questions. But like the impact on communities, how are they involved in this? What's their feedback they're giving to government, or has it really sunk down to the communities yet?
Good question. It's a mixed picture. We have, when it comes to commodities, we're already having conversations with different patient groups. We all know the HIV, TB patient groups are well established. And of course, there are fears that supply chains must not be disrupted. A quick cursory view, and this is very raw data, not processed, but we do have a few countries who seem to be okay all the way up to September. And then from September, we start having challenges in access to some of these products. And so we're really trying to run to ensure that we can at least ensure a lack of disruption of supply chain systems. Then there are community members who've heard of the cuts and who've heard of different governments proclaiming the need to change systems and redesign them better, but may not have been directly affected, particularly if they don't engage with the strategic programs. We've had a lot of calls from health providers. So these are people who sit in health facilities, and particularly the primary healthcare facilities that were highly, highly dependent on USG funding, and that are also very minimally funded by government. So actually, if you asked me as a former government bureaucrat, the biggest worry is going to be on primary healthcare, and we need to focus on that.
Nicole, do you want to, I'd love to open it up to have folks to get a couple of questions in. I see a really good one on health financing.
Yes, we have quite a few questions in the chat, which I can share and would encourage everybody else to keep adding them. So there is a question, I think this is the one you're mentioning, Bob, about how the Ministry of Finance is being brought to the table and working collaboratively with the ministries of health as well.
Thanks, Nicole. And I'll be really quick to try and get as many questions. So in some countries, they form technical working groups. So they're calling them transitional technical working groups, and the Ministry of Finance is sitting in those. In other countries, the Ministry of Health is looking inward and intends to present their plans to Treasury. So it's a mixed bag, and we do have to appreciate countries do have that sovereignty. Amref will aim to ensure that MOF is highly engaged.
Very quick. I think a follow-on question to that, similarly about the role of sort of engaging different sectors and entities. There's a question about the role that South Africa might play to convene and align a Pan-African strategy given the upcoming G20.
Yeah, so Amref is heavily engaged in the G20 conversations. We actually had our CEO this morning make a submission in the meeting that's going on in Durban on climate change. And again, this issue of transition planning was brought forth. And as we count down to the eventual culmination of the G20 meeting, we have two tracks of engagement with South Africa. And as these evolve, we'll be able to share with you our eventual outcomes. But we do have some high-level conversations and sessions on bringing together the finance and social tracks together under the G20.
Thanks, Dr. Mercy. There's a question about data based on something you shared earlier in the conversation. What happens when these data systems are stopped, and what are the short and also the long-term impacts?
What happens when they're stopped? And I speak from personal experience, it's disastrous. So I also sit on a board of a hospital that offers HIV services in Kenya. And for 1 week, we had no visibility. So we went back to manual recording. And that's what we had to do. Heavy conversations right now on who owns the data. And I think we do need to support this to ensure that data is owned by countries. We have seen some return of resourcing of data systems, but perhaps the conversation needs to be extended further into pure ownership of data, and not just by where you store it, but how you use it.
You want to ask another question, Bob, or should we wrap it up?
Sure. People aren't leaving.
There was one that just got put in the chat in follow-up to something you said about primary health care. So if you could just elaborate a little bit more on why that's sort of the biggest worry in many of these countries, and what are the exact funding constraints that are affecting that?
Fantastic. Thanks, Nicole. So PHC should have us all worried. And I speak here now even as a health economist. If you look at PHC systems in Africa, most of the country budgets support a mere 1%, 2% of PHC funding. USG, together with other sources of external funding, then picks up the rest. So it means any capacity building activities that take place at a dispensary and health center are highly externally funded. For some, the workers who work there are funded by external funding. 3, appraisal systems, performance management, externally funded. Commodities, medicines, again, partially externally funded. Nutrition programs, health promotion programs, ANC tracking, defaulter tracing, externally funded. There is actually no budget line, fellow colleagues. There is no budget line that tracks ANC defaulter tracing by most governments, because they consider that to be an external funding functionary. So you can imagine then what the situation would look like if we do not address the PHC level service delivery tiers.
I'm going to jump in with a question, because Kenya specifically, the health workforce. I've seen like data of what's happening with the health workforce in Kenya. But can you give a couple thoughts on that and what's going on? Because it just seems devastating.
Yeah, so we were, as an organization, if I'm not wrong, with the numbers, supporting close to 100,000 health workers of different cadres, so from lab technologists to community health assistants, etc. And right now, of course, some of those have had to go off work. For those who remain, there's a push for integration, but part of why our analysis will be really important in our transition planning is it's all well and good to say integration on paper, but are we losing health outcomes as we say we're integrating, and what needs to fall off even as you integrate, because it's the same one worker that now you're anticipating that they have multiple roles in the system. So I think that's one to watch. A lot of fears when it comes to the community health assistants and promoters. Some did receive a lot of, I'd say, what I'd call the OPEX costs of 100,000 people were externally funded. So their CapEx costs, their wages are government funded, but all other costs, trainings, capacity building, monitoring, etc., externally funded.
Well, thank you, Mercy, for giving so much incredible information so efficiently. We really probably should have scheduled this for everyone for an hour call, but you know, efficiency there. So really want to thank everyone for joining. And so we'll be continuing these conversations. This is just getting started. We're literally, Mercy is already processing her team all this information in 2 weeks and letting this planning going. If people are interested in, you know, learning, we're going to touch base with folks. We're going to send up kind of our structure of what this looks like and kind of the support we need for this type of project. We're going to be having ongoing conversations and face-to-face at World Health Assembly during UNGA. Amref's going to host a series of meetings on this issue, African philanthropy in general. So I think really now is more important than ever is, you know, funding African organizations, obviously Amref, but other African organizations more critical than ever because, you know, I think we're just seeing such a change. And I think the effect it will have on US NGOs, it's going to be more important that we strengthen civil society domestic capacity. And so we will be doing that, inviting in person at World Health Assembly and also at UNGA. And please share this with your networks. Our teams will be following up to have conversations more in depth on the US government things, where we need bridge funding, especially around our maternal and child health programming. That's been a big challenge. And there, I think there is a link in there if someone wants to make, you know, do something immediately and make a donation. And I don't have anything else to add. Erin, anything I've missed?
No, I don't think so. Thank you everyone so much for joining us today.
Yeah, I really appreciate your time, and we're going to keep you engaged, and there's so much going on. And I really, just going back to what Mercy said and what the conference is, this is, I think everyone in Africa is looking at this as an opportunity, not as a disaster.
Thank
Thanks.
you, everyone.
Thank you, everyone. Bye-bye.